tend to be very frequently genetically inherited. So on that note, I'm going to introduce our next speaker, who I'm sure is going to give you an even broader perspective of neuroendocrine tumors. Dr. Shereen Ezzat is an endocrine oncologist who works at the University Health Network at Princess Margaret Hospital. He happens to be my husband, so we have a very close relationship, but it's a great pleasure anyways for me to introduce him today to talk about biochemical testing.
Thank you very much. So the good news is you're going to be seeing many of the slides again. I will speak to them differently because obviously we're married, so we can't agree on everything. And that's going to be my disclosure. It's not that anybody paid me. She just asked me to shut up and not argue with her. However, I will be speaking today about biochemical tests. And I'm going to speak specifically about some of the pitfalls. And I will first and foremost tell everybody what I tell my fellows. A test is not a substitute for thinking. And it's absolutely crucial because that's really what defines artificial intelligence. Intelligence cannot be artificial, and that's the key point. What we really want to do is to be able to understand how we apply these tests, in what context, how appropriate or inappropriate are they in the diagnosis, in a diagnosis of even a patient who is already diagnosed, like what you've heard from Lynn earlier. She already had a diagnosis, but she had to deal with yet another diagnosis. And of course, recognizing how these tests perform well or not when somebody is being treated. So the monitoring is very different from diagnosis. So the first thing that I have to emphasize in terms of fundamentals of any test and how it's being applied, it must first depend on a specific suspicion. You can't just do a test because you're running it out of routine and hope that somehow it will capture the answer for you. It can't work that way. You actually, it's not, as I said, it's not a substitute for thinking. You have to be able to listen, consider what the issues are, try and distill that information in a manner that actually cohesively articulates an idea, and you're asking the test, is the answer true or false? Not just give me an answer. The other thing that has to be made very, very clear, and it's one of the things that Sylvia talked a little bit about, but we don't do it very well across the country or even across the province, and that is knowing what the tumor is actually making. Many pathologists, many oncologists don't even really think about that too much because they say, don't worry about it. We're just going to measure it. But how do I know what I'm going to measure unless I know what that tumor is really making? More importantly, if it's not making it, why do I keep measuring it? We'll talk a little bit more about that. Again, diagnosis and monitoring, two very different aspects. So those are really the three things. You have to have a suspicion. You have to think about what's going on at that time. What is it that the tumor really is making that relates to this problem, and how can we apply it to refine the diagnosis and gear the management appropriately? The myth, as she's already told you, is that a neuroendocrine tumor is just a carcinoid, and just do that urine 5-HIA test and you'll be done. Well, that obviously is totally inappropriate because, as she showed you, neuroendocrine tumors are all over the place. In fact, the largest increases in numbers are not neuroendocrine tumors of a small bowel. They're even in the rectum. The largest increase are actually at the other end, which in many instances do not make serotonin. So you can measure 5-HIA till you're blue in the face. Patient can even have widespread disease that's progressive, and guess what? The 5-HIA will be perfectly normal. How's that helpful? And as she showed you, the individual cells also make specific hormones, and we know that. But the other thing that I try to teach my fellows as well is that even when you're looking at the tissue, you have to be able to understand where these cells normally reside. Because again, we've got artificial intelligence. What does that mean? It means we have tissue, we apply antibodies, and we detect, for example, insulin and glucagon, okay? Very common situation. But you have to understand where these cells normally reside. So when I'm looking at a report of a neuroendocrine tumor, I want to know where that glucagon positivity was. Is it in the appropriate physiologic areas, or is it misexpressed, meaning it's in the wrong place at the wrong amount? It's absolutely crucial, because you can get glucagon cells that are just simply trapped in a sample. Or in fact, glucagon can be a reactive hormone to a patient who all along had an insulin-producing tumor that wasn't even recognized. And I see this over and over again. And you have to also understand the limitations, because some of these hormones get degraded very quickly, or they're made very quickly and released. Insulin is one of them. You can have a patient who's been fainting repeatedly, they have a tumor removed, and it's stained, and it's negative for insulin, and they say, oh, well, it's negative, it's not an insulinoma. Instead, they can say it's producing glucagon. Well, in fact, that's actually wrong. That tumor was making insulin so much, so quickly, that you can't even find it in the tumor anymore. It was being produced and secreted very quickly. And the glucagon was actually a reactive phenomenon. So if you don't have a pathologist who's thinking, you don't have a clinician who doesn't know what the pathologist is doing, you got a totally artificial and highly lacking of intelligence. So we've got a problem here. We have to be able to understand how to apply, even within the tissue, the test, and knowing how to interpret it appropriately, because that patient is now going to be stuck with that diagnosis, and no one is likely to go back and question that diagnosis to begin with. And as you know, in many instances, the patient can have a diagnosis 1 year, nothing happens for 3 to 5 years, and then hell breaks loose, and everybody is relying on that initial sample from several years ago that could have been done in a very pedestrian fashion. So where are guts normally? Neuroendocrine tumors, as you can see here, they're present in not just the small bowel, but I'm just showing you here of what we normally do in terms of diagnoses. And that's actually a highly artificial situation. The reason why on this slide I'm showing you why appendix is so prevalent as a site for neuroendocrine tumors is because the appendix is frequently taken out. It gets obstructed. And in many instances, no one actually thinks, why did that patient at the age of 60 suddenly develop appendicitis? Maybe the appendicitis occurred because it was actually a tumor in it that continued to grow and strangulate and obstructed the blood vessel, and that's why the appendicitis occurred in somebody at the wrong time, at the wrong place. And no one bothered to actually look at that appendix in the first place well enough. Again, we need some intelligence, and it shouldn't be artificial. The biomarkers. So one of the tests that actually I had to struggle, believe it or not, some of you who've been around long enough will remember when I moved to UHN back in 1998, we could not even measure chromogranin A. I actually had to go literally for a year to argue with the hospital about why we needed this test. Why do we need to do it? Why? It's just another test, and you can send it to Ohio or you can send it wherever. And believe me, it was a bit of a nightmare, but we finally won that. And in fact, it's a reasonable test, and I'm going to tell you right now, it's not the be-all, end-all, but it is a very important test, and we'll talk about its limitations. It's what I call the generic, sort of the no-name brand biomarker. But there are some specific markers, and I'm showing you here the ones that we commonly use, including gastrin, insulin, glucagon, vasoactive intestinal peptide. That's a very important test. It doesn't mean it's an important patient. It's a very important test for a very specific problem. We'll talk about that in a second, and the urinary 5-HIA. But one of the things that I wanted to emphasize is that any patient has to have a tissue sample that confirms for sure that what they have is a neuroendocrine tumor. That's number one. And number two, I want to know, where is this tumor likely to have started from? In many instances, patients have the biopsy performed when it's in the liver, when the cat's out of a bag. And one of the questions that many clinicians really fail to understand is that you can go back and really look for what we call lineage tracing, or what is the heritage of that tumor. Where did it really start from, or where is the likelihood that it started from the lung, from the pancreas, from the small bowel? And there are some specific markers that help us in that respect, because otherwise you're doing scans all over the place trying to find where the disease or where the primary is or was. Very, very important. And the reason why it's so incredibly important is that even in a setting of widespread metastatic disease, getting rid of the primary influences the outcome of that patient, and can eliminate a lot of the randomness of the tests and the scans that are done just looking and hoping that the primary is going to make itself obvious. That's not necessarily appropriate. So I promised I would talk a little bit about the chromogranin A, and I'm sure, just with a show of hands here, how many people here have had a chromogranin A test? Okay, so just about everybody, almost. Okay. So it is actually a member of, there's a larger family of chromogranins, and basically it's a very unique hormone that is secreted as part and parcel of any endocrine cell that is producing other hormones. So if you will, it's like a cousin of many of the other hormones that are secreted. And typically, when it is present by a neuroendocrine tumor, as the tumor increases, the amount of and the population of cells increases, and therefore we assume that there's going to be also an associated increase in chromogranin A. The problem is that, as I said, it's a reflection of hormone secretion, and it can be anywhere in the body. And right now, I'm sure many of you have had breakfast, at least I hope so. So all the hormones are actually rising in your body right now. They're trying to coordinate how you're going to digest, how the food is going to go down through our guts. And as a result, we mount a response of several hormones in our bodies, including chromogranin A. So all of us right now, pretty much everybody who's eaten in the last couple of hours is going to have a peak in their chromogranin A, which is why if the test is to be done, it has to be performed when you haven't stimulated any active phase of hormone secretion. So we say fasting. That's number one. Number two is that if you happen to be taking a medication that promotes hormone secretion, then that chromogranin A will also be persistently elevated. And one of the most common offenders are what we call PPIs, or proton pump inhibitors. Omeprazole, pantoprazole, all these ozols, basically, that are sold in the millions and millions, because they make lots of millions of dollars too. And unfortunately, many patients end up taking them, and the body's response to inhibition of acid production is to make hormones to overcome that medication. And with it, chromogranin A also rises. So we've now created a new confounder. And in order to be able to measure chromogranin from the tumor, not that as a result of the proton pump inhibition, you got to get rid of a medication. And we argue about how long the patient has to be off this medication, and whether in fact 2 days or 2 weeks or even 2 months is sufficient. And more importantly, many patients will say, but if I don't take this medication, I get more heartburn and more refluxing. So it becomes another important confounder. Very important to appreciate that. People who develop, for example, pernicious anemia because their stomach doesn't produce enough acid on its own will also have the same problem. And guess what? So does menopause and andropause, by the way. So the guys here don't want to feel like they're left out. Yeah, it's an equal opportunity situation, because when the hormone production from the gonads, from the testes and the ovaries go down, the brain reacts to that, and it starts to produce hormones that we call menopausal hormones or andropausal hormones, and with it, chromogranin A also rises. So you can see how important it is to actually keep things in the right context. Otherwise, you can be sent on a wild goose chase. And by the way, so Lynn, for example, told you about how high her chromogranin A is, or was, but you can get chromogranin A's that are in the tens of thousands, even with innocent situations such as pernicious anemia. So I'm telling you this because we now live in an age where the information is being transferred to us so quickly, and many of you may in fact be even getting your results online through a portal, and you're going to see a value that comes up, and you're going to see your heart racing, and you're going to get really worried. And I'm not saying you shouldn't get worried. All I'm saying is just stop and think. Intelligence can't be artificial. You got to think about it very carefully, and sometimes that means actually having to work with your physicians to be able to understand that. One of my favorite and least favorite tests is the urinary 5-HIA. How many people here have done a 5-HIA urinary test? All right. How many of you have been on a bus or a subway carrying one of those? I will never forget this little old lady many years ago, and she really wanted to please me so much, and it really broke my heart because she would bring this container, and then it was really very hard to completely close it, and everything was coming out from the other end, and I said to her, Mrs. X, what happened here? She says, oh, I'm sorry, but I couldn't fill the whole container, so I asked my husband to help out. And I mean, the truth be told, it was a reflection really of my inadequacy in really having to explain the procedure well enough to be able to say, look, this is really what we need to do and why we have to do it, and we've got to go through it very systematically. The bottom line is that it's a crude test, but it is a reflection of the breakdown product of serotonin. As you can see here, and in fact, there are many steps to this synthesis, and in fact, there are drugs now that are available, tilrestat, which inhibits specifically the production of serotonin and can be used to address that. But the take-home message here is that it's a crude test, a reflection of the total amount of serotonin that is being metabolized in the body. The problem is that it's one of those tests that's been around for a long time, and it's been validated in many contexts, and that's why we continue to use it. And when it's elevated and performed properly and appropriately, it's a valid, worthwhile test. And in fact, we can relate it to the risk, for example, not only of disease progression in terms of the cancer growth, but also in terms of the risk of developing valvular heart disease. So it gives us an idea of just how well we need to drive the production by the tumor of hormone synthesis. Trouble is, it's not really the be-all, end-all. It can be perfectly normal in somebody who's got progressive disease that's widespread. And it does not mean that you don't have a neuroendocrine tumor. And that's, one of the fallacies. I see this all the time. But the patient's urinary 5-HT is perfectly normal. And I say, did you actually make sure that that tumor was producing serotonin? Because if, for example, it happens to be in some part of a body that is not making serotonin, then the 5-HIA is just going to be a reflection of how much chocolates, nuts, red wine, and old cheeses you've had, right? So you got to be very careful about that. The other issue is you can measure serotonin in the blood, and in fact, you might even see it online, that some of the US marketing ploys is to be able to sell you this product. The difficulty is that in the blood, it's a reflection of how quickly your platelets are clotting together. And therefore, it has nothing to do with what the tumor is actually making. And that's, again, yet another reason why there's no substitute for serotonin measurement, at least so far, other than the crude urinary 5-HIA. I want to emphasize, though, that for those people who've had flushing, like the one that Lynn mentioned, there are also other substances that are called kinins. Essentially, they're all hormones and neuropeptides that the body produces to open up blood vessels. Unfortunately, many of these also cause pain. They cause temperature dysregulation. They make us feel really hot and unwell, and we're not able to measure them here in Ontario. So that's why I'm not saying that not too much detail. Sylvia's already mentioned to you the carcinoid syndrome. Carcinoid really implies flushing, wheezing, and diarrhea. In the numbers that I've shown here, again, the measurement of urinary 5-HIA is helpful in that respect. But I also want to emphasize the 5-HIA can also be elevated when, in fact, there's no tumor or that there's something else going on. So, for example, if you happen to have celiac disease, when you're gluten sensitive, okay? This is a situation where, again, the small bowel will start to overproduce serotonin because those cells are now reacting to an inflammatory condition. You can even see it in Crohn's disease and other inflammatory conditions of the bowel. So again, it is not the be-all, end-all, and it's very important to appreciate that in the right context, it's worthwhile. In the wrong setting, it can be highly misleading. And indeed, when I see somebody who's got diarrhea, and sometimes we measure it, and it's negative, and the patient says, but I still have very severe diarrhea. Well, what else could be going on? So one of the things that's important to appreciate, and again, as Sylvia mentioned, is that other tumors, other neuroendocrine tumors in the body can also produce the diarrhea and not rely or be mediated through serotonin. And that could be medullary thyroid cancer, for example, which is a neuroendocrine tumor of the thyroid, not the typical one, but the one that's unusual, or called MTC, which produces calcitonin, which gives you, by the way, also flushing in addition to the diarrhea. It can be quite profound, and this is a disease that's potentially highly malignant and can be lethal. The POMAs, or the VIP, this is a very unfortunate situation. Typically, it's a pancreatic tumor where the patient will have, I'm talking about the type of diarrhea that wakes up the patient in the middle of the night, and they literally lose liters and liters of fluid, and these patients can be profoundly unwell, and it's a very important situation to recognize, because once the diagnosis is made, it's relatively straightforward in terms of its treatment. But if you don't have access to measuring it, and if you don't know whether your tumor really was producing it or not, you can be in a total dark and completely miss the boat because you're relying on the wrong test. Again, artificial intelligence. Zollinger-Ellison, so gastrinomas. Many of you probably have also seen the measurement of a hormone called gastrin, which is the hormone that actually mediates the production of acid from the stomach. And such patients typically will have tumors arising from the pancreas and the duodenum, and these are called gastrinomas, or Zollinger-Ellison syndrome is basically a situation where the patient has multiple recurrent peptic ulcerations, often for years, without a specific diagnosis, and then lo and behold, somebody actually thinks about this. I already told you about the diarrhea. Most importantly also is to appreciate that in the setting of a small bowel neuroendocrine tumor, we don't just simply rely on the measurement of the test's performance and the urinary 5-HIA, but also appreciate that there can be other causes of the diarrhea in that patient. For example, sometimes it's a partial obstruction, meaning that there is indeed what we call adhesiveness, because serotonin causes something that's really very well characterized in the bowel, and that is it makes the bowel stick together, and also to the abdominal omentum and peritoneum. Thereby, it does not allow for proper flow, and as a result, you can get intermittent obstruction, which can be very, very serious. And then you get obstruction with release, obstruction, release, and that can be quite profound. And it's very, very important to appreciate this, because the treatment can be very much different. The other is that this type of tumor can also result in vascular insufficiency, which just simply means that the blood supply to the bowel is compromised, and that again will result initially in diarrhea because of reduced capacity of the bowel to be able to absorb nutrients properly. I wanted to spend just a minute about the flushing, because a lot of times patients will have a diagnosis of neuroendocrine tumor, and then they get flushing, and they say, so how do I know that it's the tumor or something else can be causing it? The flushing typically that is related, for example, to menopause is usually at nighttime. It's brought on as associated with excessive production of heat. You feel like you want to open the window, and usually it gets better as the day goes on. Whereas neuroendocrine tumor flushing typically involves all parts of the body. There isn't that sense of heat overproduction, and indeed the blood vessels become dilated like this. I had many patients over the years that were accused of drinking too much alcohol before the diagnosis of a neuroendocrine tumor unfortunately was made, precisely because of that, because of the appearance that their nose was actually getting bigger, when indeed it's a reflection of the repeated opening up inappropriately of these blood vessels in the skin. I already mentioned this about the different types of flushing. So it's important that when you communicate your symptoms to be able to describe them as well as you can. And if a physician is not asking you the questions, it probably means that he's actually not thinking about that particular symptom. Am I doing okay on time? Okay. I already told you about blood serotonin. Don't get suckered into that. It's really not very helpful. The gastrin production that I talked about in the blood is also very important to appreciate, that when the gastrin is elevated, it can be, what I mentioned before, is a reactive phenomenon. So when somebody is getting scoped to look at whether there is an ulcer or not because they happen to have a gastrinoma, we also ask the endoscopist to actually get a sample of fluid to determine whether the pH is low or not. Why? Because if you have true primary gastrinoma, then the acid production goes up and the pH will be down. Whereas if you happen to be somebody who, because of medication or because you got pernicious anemia or something else, then in fact the gastrin will be elevated in a reactive manner and the pH will be inappropriately high. So the acidity of the gastric content becomes very, very important. It doesn't cost a penny more because literally you can take a drop of fluid, the scope is already there. As you bring it up, you just take a drop of fluid, you put it on a stick and you get the pH and you know whether this is appropriately low and therefore interpret the gastrin in that context or not. Very important, simple thing to do, but often many gastroenterologists don't really think about that, and unless they're working with the oncologist and the patient really being aware of that, then really it can save a lot of hassle, a lot of difficulties. As I mentioned before, rectal neuroendocrine tumors are on the rise because a lot of people get scoped, right? And when they get scoped, they see something, and in many instances, the gastroenterologist doesn't really recognize it. They do the biopsy, and lo and behold, it comes back as a rectal neuroendocrine tumor. And now they say, oh my God, what do I do with that? And of course, it starts again, sort of hopefully a chain of reactions that include recognizing whether additional resection is required, how deep was this tumor, and more importantly, when it is ultimately removed, is to find out what this rectal neuroendocrine tumor was making. Because otherwise, guess what? That patient is stuck with doing urinary 5-HIA, potentially every 6 months for 5 years. And guess what? That tumor, in at least 40–50% of the time, doesn't even make serotonin. So you're getting the wrong test repeatedly. And that's highly inappropriate, when in fact what they really need is a test to determine what the real rectal neuroendocrine tumor is, which in many instances is what's called the L cell, and that produces, as Sylvia mentioned to you, is what's called PSAP, which unfortunately is prostate-specific acid phosphatase. It has nothing to do with prostate, but that's what the peptide is, and it is measurable in the blood. And indeed, as this really slide shows, that if you happen to have this type of rectal neuroendocrine tumor that makes PSAP as compared to the one that does not, your actual 5 and 10-year survival differs even when adjusted for all the other prognostic factors. So in other words, it's not just a diagnostic, but this is the performance of a test as a prognostic marker. Knowing the right test that's actually going to yield information to tell me whether this patient is going to do well or not, and to anticipate how to manage this patient in the long run, and more importantly, to structure an appropriate surveillance program that is geared specifically to that patient for this type of tumor. Otherwise, you're doing the test either too frequently, that's inappropriate, or not at all, or doing the wrong test. So finally, I just want to emphasize that at the end of the day, when you're making a therapeutic decision, it's very, very important that we appreciate what type of neuroendocrine tumor. And that involves, everybody knows about stage, because everybody knows about stage 4, widespread disease. Everybody recognizes that. And everybody knows about the grading with the Ki-67 of whether it's 33% or 29.9%. And suddenly 29.9 is okay for one thing, but 33 is not. And we haven't even talked at all about how that Ki-67 index is measured. Sylvia didn't talk about this, so I'm going to come back and challenge her on that, because many pathologists will, guess what? Eyeball it. Do you know what eyeballing is? It means, how tired am I at the end of a day to want to count 300 cells, 500 cells, or 1,000 cells? When in fact, in this day and age, obviously this is completely unacceptable. In fact, I think Sylvia has a paper that's going to be coming out specifically on this, where indeed you can have different paradigms with automation that actually looks at the entire tumor and counts at least 1,000 cells. So when you're looking at your Ki-67 index, first of all, remember, is it a biopsy? And if it's a biopsy, was it an aspirate or a core, which is completely different from tissue? And most importantly, think twice about that number when they say Ki-67 up to 5%. You know what up to means? It's kind of like we have a sale on up to 75%. Don't you hate it when people have that? That's exactly what it means. It means we're really going to just give you something and you make something out of it. So again, it's very, very important that if we're going to rely on a tissue, we need to know what it is we're looking for in a tissue, how these measurements were made, and how reproducible these measurements are. Because if, in fact, we're going to repeat these tests, including a biopsy, and I would argue that a repeat biopsy is a highly valid test and probably should be considered in everyone over time, because what we need to do is to be able to create a therapeutic plan for the disease as it stands now, not 5 or 10 years earlier. Because in many instances, over time, it actually changes. Or in fact, it could change as a result of different therapies, because you could have received chemo that eradicates one population, leaving you with a different population of tumor. That's a completely different situation. Another area that we really have to rely on quite heavily is working with our radiologists to ask the question, what is the extent of involvement? In many instances, people have disease in their liver, and I want to know how much disease there is in the liver, because I need to know, can I actually have a specific liver-directed therapy that can buy my patient enough time so I can save systemic therapy for when I have disease that is much more generalized in and outside of a liver. And to be able to do this, I need something that's going to quantify the amount of disease. How many segments of the liver are involved? How much disease in each of these segments? A very important finding, which is sometimes missing in one of the biomarkers, which we talk about, which is the radiology. And I know that Rebecca later on is going to talk about this, but really what I emphasize is that when you see a report, look at the quality of a report, because when it says stable findings or low or up to, I hate the term up to, you can see I'm being sort of facetious about this, but unless you have very specific measurements of what you're looking for, you can truly be misled. And the final point I want to emphasize here is that ultimately the patient's performance status. What do I mean by that? How well is the patient as a whole really coping with the disease? How are they affected? How much is really going to be related to the tumor itself, the complications related to the tumor, and other things that are, because it's an equal opportunity. You can still have heart disease and diabetes and hypertension and have a stroke and all these other things, which obviously we want to manage, because at the end of the day, it influences how well the patient is going to be able to respond to different therapies, some of which will have some very serious complications. So we've got lots of drugs, we've got all sorts of things that a lot of, unfortunately, medical oncologists have become sort of polarized, because that's what, as physicians, we get bombarded with. We get bombarded with this sort of thing. We look at the cell, we look at the drug, we look at the trial, we look at the outcome, but we lose sight of the picture. The big picture really is, how well is the patient doing, and how does it all really relate to the performance of that patient. So I'm going to end just simply by saying that really at the end of the day, we need a lot more intelligence, less artificial, much more of a human intelligence that is needed between people who work together with the patients, with the team, and recognize that all of it has to be done in a very cohesive manner. Thank you so much for your attention. Happy to answer any questions.